Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So I'm going to kind of take us down a trip to memory lane because as I'm doing some audits lately, I'm noticing that people haven't really changed their E&M templates from the 2019 or even before that, templated information, drop-down screens, and the 97 or 95 guidelines. And people don't realize that in 19, there was an update. And then there was an update in 21 that totally changed, 2021, that totally changed the I don't want to say the platform, but I guess the mindset of E&M services. So I just want to do a comparison so that you're kind of understanding where to go with this. And hopefully you've had, whether you have NextGen or Epic or, whatever your system is, that Microsoft, that you have taken steps in the last 4 to 5 years to update your information, because I'm telling you, the audits still look like the same information, and the information now in the medical record charting, we don't score it the same way to get the end result of a level of service. And so it's really a problem when everyone says, oh, I'll just use this, but then I'll apply this methodology when the methodology doesn't apply to the template. So here's kind of the definitions of E&M prior to 19. So we want to kind of go back and take a look. So HPI, or chief complaint. Chief complaint is the reason the patient comes in. So why is there even an interaction between the patient and provider? What's the patient, in their own words, complaining of? You still have that, 19, 20, 21, and now in 24. History of present illness, or the HPI. Those are symptoms that describe the nature and severity of the patient's presenting problem or problems. Now in 2019, we had a change where CMS allowed ancillary staff to document the HPI on behalf of the provider, but the provider still had the responsibility for verifying that accuracy of that collected information. And because this was a Medicare change, not all individual payers or state Medicare programs were following it. Additionally, Medicare or CMS also allowed the provider only to document interval changes from the previous encounter, but it had to reflect in the documentation specific to those HPI elements. And the other thing is that if you're basing your E&M service level on time, you couldn't use that staff work. So even though they said, yes, you can do it, that staff work could not be included. It has to be whatever work is personally done by the provider after 2021. In 2021, as far as HPI, the same thing applied. HPI should describe the nature and severity of the patient's presenting problems as medically indicated, but I just don't use it to score the purpose of the E&M, but I do use it for medical necessity for the encounter. Same with review of system. So again, that had to be, part of that presenting problem, how each organ system was impacted before 2019. The ancillary staff could then add some information, but the physician documentation still had to be the one that updated it. And I don't use that now in scoring since 2021. The same thing with the past family social history. So that had to be areas of concern within the patient's personal, social, family history that could impact their current problems that they're coming in for. But then in 2021, the changes were you still need to use it to capture medically appropriate information, but it's not part of scoring. That actually helped to not have it part of scoring, because if you remember, you could have a beautiful, extensive or comprehensive history, but your physician leaves out the past family social history, and what could have been a level 5 gets down coded to a level 2. That's not the case anymore, but it still has to be medically appropriate. Then we get into the exam, that quantifies the hands-on physical exam work provided by the provider, and you could document either 95 or 97 guidelines. And then when we get to the 2021 rules, the exam has to be medically appropriate. It is determined by the provider. So there's a lot of trust there, the provider of care today, And we don't, again, use this component to score the E&M, but it still impacts the level of service based on medical necessity. So if the patient's coming in for ankle pain and I don't see an ankle or musculoskeletal exam, then it's not medically appropriate. I saw some providers saying, well, I did a neuro exam for somebody who was coming in for chest pain. That's ridiculous. So it has to be, problem pertinent for that to be there. So some of these liberties or some of this trust that AMA and the people who are writing up these guidelines put there have actually hurt physicians in the process because their workflows, they've kind of let them go kind of lax. Encounter diagnosis. So before 2019, this section credits the provider for each diagnosis treated based on the documentation, but that's not the case in 2021. Now the guidelines indicate that only diagnoses documented as active treatment during the encounter are credited for scoring purposes, and also the revised table of risk was updated and it removed the additional workup consideration for each diagnosis as the overall risk on that patient. Data and complexity. So that was a point system as well to quantify the amount of work performed with respect to obtaining and or analyzing medical data like diagnostic tests that went beyond the physical. And the AMA took most of the elements of the Marshfield Clinic of the data and complexity and incorporated them there, but they also included new requirements for specific combinations of different work elements as well to support a specific level of service, and you need to look at those categories. Table of risk, and this was the highest level of risk of mortality or morbidity posed by the presenting problems, ordered tests, etc. But the table of risk was revised in 2021, consolidating it into one column or one of the elements of medical decision-making table. And it's the last column now for options in the management of that patient. And management is a really big deal. And then time was definitely something that was interesting because the use of face-to-face time spent with the patient could be a determining factor prior to 2019. But it basically, I should say prior to 2020, but it was if you spent, and I'm air quoting, 50% or more, of that time counseling the patient. So the changes for time, the limitation of the use of time was deleted. So there's no requirement that it has to be dominated by counseling or coordination of care. But it now includes the rendering provider's total time spent on the day of the encounter for that specific encounter for that patient, and it's the time personally spent by that provider. So staff time is not included in that. And I think some of these things are definitely missed when we're looking at old templates. Also, just to update medical necessity when it comes to acute or chronic conditions. Looking at acute, patient presents today with an acute presenting problem. So that means that, for example, level 2, the problem is minimal in nature and questionable if the patient even truly needed to be seen on that given date of service. So it might be acute to the patient, but not really to the physician. Level 3, problem is acute and uncomplicated at presentation to the provider. Level 4, acute with complicating factors, could be some things contributing to the complexity of the care for the patient on today's date of service. And then we know level 5, basically we kind of call those a train wreck. Acute illnesses and injuries that pose a threat to life or bodily function, or an illness if it's behavioral health with potential threat to life or others. When we get into chronic levels of service, the problem, let's say for level 2, would be minimal in nature. Again, questionable if they even needed to be seen, if it could have just been a triage phone call without a charge. Or is it a stable problem and not exacerbated? Or is it a chronic problem that could be exacerbated, decompensated, or maybe there's a adverse effect of 2 or more. And then level 5, those chronic illnesses have severe exacerbations, progressions, or side effects. So always keep in mind, throwing these things in there, just saying it's acute or chronic and not really having that clinical understanding. Go to your medical dictionary. Go find those things that you're struggling with, and then apply that to your medical record. Otherwise, you're going to either overcode, undercode, or miscode. And I am seeing that happening quite a bit, and it's a problem. So I do have a coding question today, and this is a good one. This comes from a new coding corner client. And Anne, thank you for the question. It says, how is a laparoscopic appendectomy for an indicated purpose that is performed at the time of another procedure coded? So she said indicated, not incidental. So I'm going to answer both questions actually, because a CPT assistant has weighed in on this and said you need to use the unlisted code 44979, but the CCI edits say 44970. But here's the scenario. A provider performs surgeries for endometriosis, will often remove the appendix regardless if there is documentation of pathology. Yikes. Is it appropriate to bill the patient for this service with an ABN, or is it appropriate to charge for that with an appropriate modifier indicating an ABN's on file? So not just the CPT assistant, but here is what Medicare says. And Medicare actually is very clear on this. So this comes in the Digestive System, Chapter 6 of the National Correct Coding Initiative Policy Manual. And I'm actually going to be on page 6. I've actually highlighted this under abdominal procedures, which is section E, and it's under VI 7. It's number 3. It says a medically necessary appendectomy may be reported separately. However, an incidental appendectomy of a normal appendix during another abdominal procedure is not separately reportable. Now, that's not laparoscopically. So then you have to go to page 10. So that's just regularly cut open the patient. Now, when we talk about, laparoscopic services, talks about lysis of adhesions. It's not separately reportable with other laparoscopic procedures surgically. But number 6 on this one, and this is under F, talks about laparoscopic appendectomies, which is kind of the topic here. And this one says CPT code 44970 describes a laparoscopic appendectomy and may be reported separately with other laparoscopic procedure codes when a diseased appendix is removed. So it has to be part of the disease process. Since removal of a normal appendix with other lap services or lap procedures is not separately reportable, this code shall not be reported for an incidental laparoscopic appendectomy. So going back to the question from my new Coding Corner client, when the doctor is taking it out because they just happen to be there, you can't code for that. Doesn't matter what the other services were, if it was a good idea at the time, but if it's not medically necessary to the disease process for that particular procedure, you can't charge for it, you can't make the patient pay for it, and it would not be appropriate. So know the difference between incidental and if it is an indicated procedure. There's also an add-on code for an indicated procedure. I think it's 44955 if I'm not, let me look it up here if I'm not mistaken. Yes, 44955. See, I haven't even done these in a while and I know the code. So when you're looking up these services and you're trying to figure out, well, what if it is an indicated purpose? There is a reason to do it, but it is with a abdominal surgery that has a, you want to get paid 100% of. Well, 44955 says appendectomy when done for indicated purpose at the time of another major procedure and not as a separate procedure list in addition to the code. So that's an important add-on to know. But again, indicated versus incidental. So make sure you're aware of that before you try and report something that may not be appropriate. Okay, so my personal tidbit today is kind of fun. I've been nominated for 6 years in a row, which for the People's Choice Awards for a podcast. You can go to podcastawards.com, and as of August 1st, you can now vote. So go under Best Female Podcast. Thank you for those of you who nominated me. I appreciate that. Look for Codecast Podcast and vote for me. I really would appreciate that. So we've been top 3 in a couple of the years, and we just hope one day we might win now that we're at 1 million downloads and listens. So again, everyone, thank you so much for that vote of confidence, for listening to the Codecast podcast. It's truly appreciated. Make it a great rest of your week. Have a great day. And again, thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.